Hi, everyone. Thank you so much for joining us today. We're very privileged to have Dr. Michel Tchan and Kate Billmore ready to present for us on classical homocystinuria. Michael, it's great to have you here. Thank you so much for joining us, and we really look forward to your presentation. Michael is the head of genetic medicine at the Westmead Hospital, and it's an absolute pleasure to have you here, Michael. Thank you.
Thanks very much, Mel. Look, I'd just like to take the opportunity to thank HCU Network Australia for the opportunity and invitation to speak tonight. We're going to talk a bit about therapies, and what I'm hoping to do is pitch this, hopefully at the kind of right audience. But I know we have a bit of a mixed audience tonight, so apologies if it's not pitched quite right. But I'll do my best. So I'm going to talk about classical homocystinuria. So as this audience knows, this is a genetic disorder of the metabolism of an amino acid called homocysteine. It's due to genetic faults in the gene that encodes this enzyme called cystathionine beta synthase, or CBS. And as a consequence of that enzyme deficiency, the body can't get rid of homocysteine. And you can see the chemical formula for homocysteine there. And so the homocysteine just builds up and builds up in the body and can get to very high levels. And I've made the comment there of totals of more than 100 micromolar, when the normal is, it depends on the lab, but it's usually less than 15. So it's markedly elevated. And some people with homocystinuria can have levels 200, 300, very high levels. So markedly elevated. And bear with me, guys. I'm sorry about having pathways, because I know it's not ideal, but it's really the easiest way to try and explain what's going on in this really rather complicated disorder. But you can see here, I wonder if I've got a pointer, I may not, but in the middle of the slide there, there is the compound homocysteine in red. And what's normally supposed to happen is homocysteine is supposed to get changed into this next compound called cystathionine. And if it can't do that, then instead of going downwards towards cystathionine, then it goes back up the pathway to this thing called methionine up there. And the reason in homocystinuria that doesn't happen properly is because that enzyme, which you can see there by the marker number 1, is deficient. So that's where the CBS enzyme sits. There we go. So the other thing about this pathway that's important is that each of those little numbers represents an enzyme that does a step in the chemical pathway. And for this condition, it's step number 1, CBS, is the problem. But you can see there's a number of other enzyme steps there as well. And what I've also brought up is these little labels Bs, and they stand for vitamins. So vitamin B6 and vitamin B12. And they're there to indicate how important they are for the enzymes. So the enzyme needs vitamin B6 to work, but there's also another point up there that needs vitamin B12 to work. And the other vitamin that's not clearly labeled there is the vitamin marked as THF, which is folate, also a very important vitamin in this story. So apologies for the pathway there, guys, but it becomes important later on. So I won't labour this slide very much, but I think the audience knows about the various clinical features of homocystinuria, so I'm going to just skip through this one and move onwards. But it's important to recognise that homocystinuria is classified in different ways depending largely on how well a person's body responds to additional vitamin B6 or pyridoxine. There are some patients who, you can see there on the right, are what we call full responders or extreme responders, and their homocysteine level drops really beautifully if you give small doses of vitamin B6 or pyridoxine. There are some people who respond partially, and then moving to the left there, you can see there's a proportion of people who don't respond at all to pyridoxine. And this all comes down to the genetic mutations that are found in a particular person. So about half of the patients, we think, respond to pyridoxine, but for those who don't, it's a more severe condition, and they can have difficulties with learning. They can have other neurological things like seizures and whatnot as well. So there's various things that, depending on how responsive you are to pyridoxine, will define how severe your condition is. So when we look after people with homocystinuria, we measure a whole bunch of things to try and help us get a feel for what's going on. And excuse it's probably a little bit small, but there's some things that are important that we measure. So my slides aren't progressing. Here we go. But the most important one is this thing called total homocysteine. And that's the one that really tells us what's going on in a person with homocystinuria. The other chemicals that we measure are methionine and a few others, but you can see the top arrow there links across to this chemical called methionine. And you may remember that pathway, the link between homocysteine and methionine. So we measure those things to work out what's going on. And what we're hopefully aiming to do is really prevent all the complications of homocystinuria. We want them to have normal growth and nutrition, and we want our patients to have normal opportunities for employment and family life. And that's looking as though it's feasible for patients who get diagnosed through newborn screening and are treated very early in life. But of course, many patients haven't been so fortunate and they were diagnosed a bit later in life. And so our goals are really to prevent complications, particularly blood clots, what we call thromboembolic disease. So those blood clots are the really concerning feature that we want to try and avoid. So how do we try and reach those goals? Well, if they're pyridoxine responsive, then we would hope that people can reach homocysteine levels of less than 50. But for those who are not responsive, we hope to keep their homocysteine levels less than 100, and that seems to do a good job of preventing blood clots. I won't labor this slide too much at all, but essentially there's a bit of a pathway or a process that goes into working out if someone's going to be responsive to pyridoxine or not. We have to give them a couple of doses and keep them on a steady diet and then measure their levels again over the course of 2 or 6 weeks, depending on the age at which they're diagnosed. And through that sort of 6-week process, we can work out if someone's pyridoxine responsive or not. But we do have to be a little bit careful because actually pyridoxine's not entirely safe. You can get what's called peripheral neuropathy, which is numbness and weakness of the hands and legs if you give too much of the stuff. So we do have to be a little bit careful. And when we give it to newborn babies, particularly as part of that pyridoxine responsiveness test, we have to be a little bit careful also because they can have quite a nasty reaction to it that's reversible. How much of pyridoxine do we give? Well, we give 10 milligrams per kilo, but for adults, we only go up to 500 milligrams because we want to try and avoid that complication of pyridoxine related peripheral neuropathy. And then for the other 2 vitamins that are important, we don't really know how much we need, but we should make sure that people aren't deficient in folate and B12. And Kate is likely to just give us a couple of words about where folate and B12 come from in our diet. We want to try and avoid any deficiency of those. In terms of dietary treatment, what our goal is for patients that are not pyridoxine responsive and so have higher levels of homocysteine, well, how can we lower the homocysteine levels? And one way to do that is through manipulating a person's diet. Because where the homocysteine comes from in the diet is from protein. It comes from protein in our diet, gets broken down in our bodies down to methionine, and then the methionine travels around that pathway down to homocysteine. So if we're able to give someone a diet that's really low in protein, then at the same time, we're automatically giving them a diet that's very low in methionine as well. And that enables the homocysteine levels to come down. But it's tricky to do. It's not a pleasant diet to have to follow because, of course, people like protein and protein's in all sorts of things, not just meat and fish and whatnot. So, but Kate will talk more about that later on. Treatment can be difficult to initiate because of the difficulty of the diet, particularly people who are not used to the diet. So people who get diagnosed later in life, it's a bit tricky. And we tailor the diet depending on what their levels are, both homocysteine and methionine. The next treatment that we use in patients with homocystinuria is this chemical called betaine. Now, betaine is something that's found naturally in the body and in our diet. It's also found in all sorts of foodstuffs as well. So although, yes, it is a medicine, it is also a naturally occurring compound. The way that betaine works is that you can see right in the middle of the pathway here, I've drawn another nice red arrow. So instead of homocysteine going to methionine around that arc, which is labeled as number 2, instead it grabs hold of the betaine and undergoes a chemical reaction and turns it directly into methionine via a different enzyme, this one called betaine homocysteine methyltransferase, or BHMT for short. So The value of betaine is it allows us, or allows your body, a different way to shoot the homocysteine back to methionine, um, and so avoiding the high levels of homocysteine. We use it in conjunction with diet, and generally we give a weight-based dose in kids, and we tend to stop the dose at about 3 grams BD in adults, although there are certainly patients who are on a bit more than that. We don't have good evidence, I don't think, to tell us which dose should be used. But it's a powder. You can pop it in a drink or something like that, and people need to take it a couple of times a day. There are some possible side effects, the first of which is more common than the second one, thankfully, but the first one is a slightly fishy odor, and that's got to do with the way that the betaine is metabolized in the stomach. Secondly, the betaine can cause problems if it works too well, in a sense. So you will remember the homocysteine binds with the betaine and goes back to methionine. If it works too well, the methionine levels can get very high, over 1,000. And there have been a couple of cases in the literature over the decades where people suffered from swelling of the brain. Thankfully, it seems to be a reversible problem, but we do try and keep the methionine levels to under 1,000 if we can. I'll just quickly mention zinc here. Zinc's probably an important cofactor, just like vitamin B12, folate, and pyridoxine. Zinc is probably an important cofactor for this BHMT enzyme, which is the one that utilizes the betaine. So good to make sure your zinc levels aren't too low as well. So they're the traditional kind of treatments that we've been able to use over really decades now, and they work reasonably well. And this is a graph that shows some of the data telling us, well, how well does it work? So the left-hand picture there, you can see the red boxes are the different groups of patients with homocystinuria, the non-responders to pyridoxine, some partial responders. I won't go through this slide in detail, but what you can see is that if you put patients on the treatment, that's the diet and the betaine and pyridoxine, then their homocysteine levels drop nicely, and as do their methionine levels as well. The patients who are full responders and extreme responders to pyridoxine, on the right-hand sides of both graphs, you can see their homocysteine methionine levels go from the big red boxes right down, and they drop enormously down to the little green boxes on the right. So you can see how well they respond to treatment. Patients who are non-responders don't tend to non-responders to pyridoxine don't tend to respond to the full lot of treatment as well. And so there's certainly a gap in terms of our treatments. They're not perfect. They're not as good as we need them to be. However, they do work pretty well. So these are not so much the biochemical outcomes, but the clinical outcomes. So the box on the left is the blood clot outcomes, and the grey lines are the number of people who don't have a blood clot with time. And you can see the grey line declines pretty steeply over the first 10 to 20 years of life. So many patients who are untreated and diagnosed late do get blood clots. If we put them on the treatment, then they move up to the yellow line, so they do a bit better. And those patients who are treated from birth are the blue line, and you can see that they really do comparatively well compared to people who are diagnosed later in life. Similarly, the right-hand box that you can see there is the number of people who have dislocations of their lenses. And we can see that the diet and betaine treatments that we have don't work as well as they do in preventing blood clots, but they do still seem to have some sort of effect. And we do see that even with the newborn screening or early screened patients or early diagnosed patients, they certainly do much better. So moving on, they're all the traditional kind of treatments and how well they work. So moving on to new things. What's coming? What's in clinical trial? What's happening? So the first thing, probably the most advanced of the newer treatments that is coming, is a thing called pegtibatinase. Now this is a synthetic version of the CBS enzyme. So you remember the CBS enzyme is the one that's missing in people with homocystinuria. So this is one that's been made in the lab, and it's given by a little needle under the skin, what's called a subcutaneous injection, and it's given twice a week and is designed to work in the body to replace the enzyme that's missing. So it allows the homocysteine to be broken down by this synthetic version of the CBS enzyme. There have been a few studies. So the first study was really about safety and to see how tolerable it was, but they were able to show some really nice results in the reduction of homocysteine. And I've got a graph next slide that'll show us that. But having done that small study with just a few people, they've moved on to a bigger study called Harmony. And then after that, they'll move on to a study called Ensemble. But the Harmony study is aiming to look at 75 patients worldwide and do a comparison between placebo and pegtibatinase to make sure it works and see how well it works. I will note that last year, the company who are making pegtibatinase put a hold on the study, so we couldn't enroll any more patients because they're trying to work out how to make the drug on scale. They're hoping to re-enroll people in 2026, but we don't have results of the Harmony study yet. But the next slide, this one will show us what they found in that earlier study with just a few patients in each. And I'll draw your eyes to the red boxes over there where they had 2 or 3 or 4 patients and they gave them doses of pegtibatinase from either 1 milligram per kilo up to 2.5 milligrams per kilo. And what I'll get you to look at is it's the second line. So you can see the baseline mean, and that is the level of homocysteine. So those numbers 175, 186, and 96. So that's what the patient's homocysteine levels were at the start. And then when they finished is the next line down, and you can see the significant reduction in the homocysteine levels of these patients when they were given this drug twice a week. So you can see certainly the early studies looking pretty promising. The next thing, I'll just quickly slide through this one. So this is not yet been given to any people at all. So this is a modified enzyme like the last one, like pegtibatinase, but it does a different thing. This is a synthetic enzyme that actually acts in the stomach and breaks down the methionine in the protein before it even gets absorbed. So this is a different idea to the pegtibatinase, but the idea is that a patient could, in theory, eat a normal meal and they would absorb all the protein except for the methionine, which is the one we want to try and avoid. But again, not yet in human trials, but look pretty good in mice. There are some people trying to do gene therapy. What gene therapy means is replacing or substituting the dysfunctional gene in a person's body. So the way that that's done is a little correct version of the gene gets engineered into a virus, and the virus gets injected into the person, or in this case, the mice. And then that little correct version of the gene goes into the person's body, generally goes to the liver mostly. And from there, it does the job that it's supposed to. And at the moment, I don't think any people have been dosed with gene therapy for homocystinuria, but certainly the mouse work by Warren Kruger shown some nice results there. And you can see this picture is on the left is a little mouse who has homocystinuria, and on the right is his sibling who's been treated with gene therapy. And even just looking at them, you can certainly see the difference. I want to finish up with one last study or piece of work that's been championed by a doctor called Ken McLean, who's been working on this for quite some time. And what he, here we go, you thought the pathway was better before. Anyway, what his theory or approach is that when we look at our patients with homocystinuria and we treat them with betaine, what we often see is they respond quite well initially, but fairly rapidly the response is less than perfect. And Dr. McLean has worked out that one of the reasons, most likely, that the response is less than perfect is that the betaine, after it reacts with the homocysteine, then needs to be broken down. And if it's not broken down, it then comes back and stops the whole process working. It's what we call an inhibitor. So and for that process to work, on the very right-hand side of the slide, you can see 3 lots of this thing, THF, which stands for folate. So for the betaine to be broken down, the body needs a lot of folate. And Dr. McLean's theory is that it's the folate that gets low in a person's body after a bit of treatment with betaine. And if we could reverse that process, then the betaine would work better. The little pathway on the left is just showing a chemical called formate, and formate works in the folate pathway to regenerate the folate. So that's the theory. Now, when Dr. McLean tried this on mice, I'm just going to leave this slide up for a minute because you can see the dramatic effect on the homocysteinuric mice when they were given both formate and betaine. So even the formate on its own helps, but you can see the large left purple box has levels of over 300. And then when the mice were given both formate and betaine, the level dropped down well below 50. So quite a remarkable response in mice, at least anyway. So with that laboratory background and Dr. McLean's enormous amount of work, there's now a company who are trying to bring this to the clinic and bring this to patients. And we're just about ready to set up a clinical trial of calcium formate here in Australia. There are sites in Sydney, Melbourne, and Adelaide. And we hope to find 12 adults with homocystinuria. We'd like to try calcium formate with them, see how it goes, see what the homocysteine levels do, see if it's safe, see if it's tolerable. And yeah, we hope that this may be a really valuable addition to our current regimen of treatments for homocystinuria. And hopefully it would be great to bring the levels down and allow people to have a much more normalized diet.
Michael, thank you so much for your fantastic presentation. And it's just wonderful to hear about the research that is going on in the treatments of homocystinuria. So it would be my pleasure now to introduce Kate Billmore, a dietitian who's going to give us a fantastic presentation about the diet considerations in homocystinuria.
Welcome everyone, and thank you for inviting me to present this evening. I'm Kate Billmore, a metabolic dietitian at Westmead Hospital. As I work with adults, my presentation will be adult focused, but hopefully there'll be some useful information for everyone. This talk is aimed at providing a practical overview of managing HCU through diet. Here's a brief outline of what I'll be covering. I'll begin with an introduction to HCU, its symptoms and treatment options, then explore how diet plays a role, including low-protein foods, supplements, and practical meal planning. We'll also touch on real-world challenges and key takeaways. Homocystinuria is an autosomal recessive disorder caused by a deficiency in the CBS enzyme. It occurs in about 1 in 100,000 individuals in Australia and New Zealand. Newborn screening began in New South Wales around 1996, but adults born before that who miss screening may face delays in diagnosis and have greater difficulties when it comes to drastically modifying their diet. Some people with HCU are responsive or partially responsive to vitamin B6, which is also called pyridoxine. People who are not fully responsive generally require some degree of dietary modification to achieve safe homocysteine levels. HCU symptoms can affect multiple systems. It can cause visual problems, neurological symptoms, skeletal issues, and vascular complications like thrombosis. These vary depending on the severity and responsiveness to treatment. This figure shows the metabolic cycle of methionine. In HCU, there is a problem with the CBS enzyme, which prevents homocysteine converting to cystathionine and results in a buildup of homocysteine. High levels of homocysteine cause the symptoms outlined in my previous slide. For those with pyridoxine or vitamin B6 responsive HCU, high doses of pyridoxine are used to boost CBS enzyme activity. This allows homocysteine to be converted to cystathionine and prevents the homocysteine buildup. The recommended dose is around 100 milligrams twice daily, which is much higher than the recommended dietary intake of 1.3 to 1.7 milligrams per day. People who are fully responsive to B6 do not require dietary intervention. In B6 non or partially responsive cases, diet becomes more important. As methionine is an amino acid, which is a building block for protein, a low-protein diet is recommended to reduce methionine intake and thus limit the buildup of homocysteine. If protein has to be restricted below the RDI to achieve safe homocysteine levels, a methionine-free amino acid supplement is required to ensure that protein requirements are met, in addition to vitamins and minerals that are missing in a low-protein diet. A pharmacological dose of folic acid is also generally prescribed to ensure adequate supply for the remethylation pathway. Betaine may be added for some non-responsive patients. It remethylates homocysteine into methionine. However, high methionine levels can be dangerous, potentially leading to cerebral edema, so careful monitoring is essential. We aim to keep homocysteine levels within targets, which is less than 50 micromoles for responsive types and less than 100 for non or partially responsive types. These targets help to guide the level of dietary restriction needed. The goal of dietary treatment is to limit methionine intake while maintaining nutrition. If homocysteine levels necessitate a protein restriction below RDI, an amino acid supplement is required to ensure adequate protein intake and vitamins and minerals that would otherwise be missing in a low-protein diet, especially micronutrients like B12, iron, calcium and zinc, which are found in meat and dairy products. As previously mentioned, methionine is an amino acid found in all protein-containing foods. Because food labels don't list methionine content, we rely on protein counting instead. However, it's important to note that meat, eggs and dairy have higher levels of methionine per gram of protein and are therefore best avoided if possible. I prepared this table using data from the USDA, where methionine content for over 5,000 foods was measured. I used this data set as Australian food tables only analysed 180 samples and the sample size for some food groups was too small. As you can see, methionine per gram of protein for eggs, meat and dairy quite a lot higher than the other food groups. For this reason, it may be best to limit the intake of these foods. On the other hand, fruits and vegetables have a much lower methionine content per gram of protein, which is why we use separate counting lists for these foods. This is an example of our separate protein counting list for fruits and vegetables. It has information on how to weigh foods and lists some of the free foods that don't need to be counted in HCU. Meal planning is crucial to ensuring success with a low-protein diet. Most common foods can be substituted with low-protein versions. These are available from specialty suppliers and sometimes from supermarkets. There's also a wealth of recipes online. Now, I'm just going to talk very briefly about how to substitute some common food items for lower protein alternatives. This advice is general and you should always check the labels and talk to your dietitian for more support. So I'll start with bread, which is a staple, but regular varieties found in the supermarket are usually too high in protein. Unfortunately, there's no longer any ready-made low-protein bread available in Australia, but there are some low-protein flours to make fresh bread, and they are arguably much nicer to eat. Many gluten-free options in the supermarket are much lower too, but you should also always check the label. So just to give you an example, a normal slice of bread found in the supermarket can have between 4 and 5 grams per slice, whereas gluten-free is closer to half to 1 gram per slice. An example of a normal bun versus a gluten-free bun, this one's significantly lower. Pizza bases, a gluten-free base is less than half the amount of protein. Your specialty flours are considerably lower than any you'll buy in the supermarket, and you can even get things like gluten-free crumpets, which are much, much lower. Switching to a specialty low-protein pasta is a really easy way to reduce your protein intake while maintaining some filling foods in your diet. Low-protein pasta tastes much the same as standard pasta, but there's a bit of a knack to cooking it, so if you're having difficulties, your dietitian can help point you in the right direction for resources. You have to be a little bit aware of gluten-free pasta in the supermarkets because it's still quite high in protein, unlike some of the gluten-free breads. Bean thread and rice noodles are excellent low-protein alternatives from the supermarket. So just some examples here. As you can see, gluten-free pasta is still quite high in protein, whereas some of your specialty low-protein products are considerably lower. The same applies to rice. This is an example of bean thread noodles, which are very low in protein, and you can also use vegetable rice and noodles. Low-protein dairy alternatives include nut, coconut and rice milks. Supermarket vegan cheeses and coconut-based yogurts or ice creams are also great low-protein options. There's also prescription protein-free milk available. So here's our example of using normal milk versus a prescription milk, which has no grams of protein. Your rice and nut milks, as you can see, are much lower. Cheese has about 7 grams per 30 grams, 7 grams of protein per 30 grams, and there's a whole heap of vegan cheeses now which have none. Also, your yogurts, so coconut yogurts are much, much lower. So most vegan meat alternatives from the supermarket are still very high in protein and therefore not suitable on a strict low protein diet. So label reading is very important. Some specialty low protein products are available from suppliers. So meat generally has around 25 grams per 100 grams. Now these burger mixes from specialty suppliers are considerably lower. And you can sometimes find some suitable foods available in the supermarket. They're still a little bit higher than from the specialty suppliers, and it's really, really important to read the labels because often they're still made using high protein foods. So you can also buy egg replacers from specialty suppliers. So just these little switches can make a really big difference to reducing your protein intake. At Westmead we have lots of patient resources, so the fruit and vegetable list which I went over before, some information on label reading, and we also have lots of different food lists, so we find our patients find them very helpful. Okay, next on to supplement. As mentioned previously, an amino acid supplement is required for many people with HCU following a low protein diet as it ensures that protein and essential nutrient requirements are met. Protein is essential as it provides the building blocks needed for growth, repair of tissues, enzyme production, and overall body function. Amino acid supplements also ensure that protein catabolism does not occur, which can increase methionine in the blood. People with HCU must meet their daily RDI for protein. Some of this will be from natural protein and the rest from amino acid supplement. Protein requirements from amino acid supplement should be increased by 20 to 40% to account for increased oxidation and absorption. So, for example, a 75 kilo person has an RDI of 60 grams of protein per day. If they have a 15 gram natural protein restriction, they require an additional 45 grams of protein to meet their RDI. As this will be made up from amino acid supplement, we need to add 20 to 40%, so this person needs between 54 and 63 grams of protein equivalent from supplement to meet requirements. So there's lots of different types of supplements, or a few different formats anyway. So we've got ready-to-drink options, powders, and we also have tablets. So it's just important to note with the tablets that they don't contain vitamins and minerals, so we usually need to give additional supplementation of just the vitamins and minerals. And while supplements in tablet form work really well for some people, a very large quantity is required. So you need 22 tablets to give you 20 grams of protein, so they're not for everyone. So this sample meal plan will just give you a bit of an idea about how you can follow a low protein diet with homocystinuria. So an example for breakfast that has 5 grams of protein, you could have a slice of gluten-free bread with butter, some free fruit, a cup of cornflakes with some almond milk, and then one of your low protein supplements. For lunch, you could have a cauliflower and pasta salad. So cauliflower is a counted vegetable, so if we use 160 grams of that, that's 1 gram of protein. You can use your low protein specialty pasta, no grams of protein, 55 grams of pomegranate, another counted fruit, so that's 1 gram of protein, some vegan feta, which is free. Then you can add things like olive oil, fresh herbs, or other free vegetables, and another supplement. So we always like you to have supplement with meals if possible. So for dinner, 5 grams of protein, 20 grams of protein equivalent. We could do some vegetarian tacos. So 3 taco shells will give you 2 grams of protein. 90 grams of avocado is another gram. Some pickled onion for free. You can use some low protein burger mix and add in some taco seasoning. That's 2 grams of protein. And then you can mix it up with some salsa, fresh herbs, cabbage, tomato, any other free vegetables. And we'd do another 20 grams of protein equivalent from supplement. So we'd have 2 grams left. We're having 15 grams a day, so we have different snack lists. So fruit's always a good option because most fruits don't contain protein, and there's some other ideas for sweet and savoury snacks here. So managing HCU isn't just about science. There are real life challenges from late diagnosis to the social and emotional toll of strict diets. So education, access and ongoing support is essential. So to summarise, homocysteine is a rare but treatable metabolic disorder and tailored management is critical. Diet is central to treatment, especially in B6 non-responsive cases. A strict low-protein diet with supplementation prevents complications. Practical support is essential, including education, specialty food, and resources to support adherence. Monitoring is key, so regular appointment attendance helps tailor treatment to keep homocysteine within safe limits, and patient-centred care matters. Social, psychological, and lifestyle factors must be addressed for long-term success. Thank you so much for your time.
What a fantastic presentation, Kate. Thank you so much. I really appreciate that. And it's great to have Kate with us for the Q&A. We do have some questions coming through, which is fantastic. So thank you to all of our audience members for submitting their questions. We'd love to have more of them. So please do submit questions as you think of them. And we have our wonderful panel here of Michael and Kate ready to answer our questions. So we're going to start with a question for you, Michael. And that is related to formate. So we've got a question from Ben Fitler saying, thank you very much for your presentation. How is formate administered and how long do you expect it would be for formate to be a treatment option if all does go well with the medical trials?
Right, thanks, Ben. The formate is being made up as a compound called calcium formate, and it's going to come as a tablet. I think the tablets are 12 millimeters long, so they're not tiny, but they're also not enormous either. So people will be taking those tablets a couple of times a day. We're really early phase at the moment, so the calcium's been given to people without homocystinuria so far, and it's been safe for so-called healthy people. The next step is this trial we're about to embark on, the so-called phase 2 trial, and that's going to go for 12 months. If that goes well, it's likely that the company will then take the next steps to what we call a phase 3 trial, which is a bigger trial, looking for more patients to evaluate on the treatment for 12 months, 2 years, 3, 4, 5 years. And so we're not looking at calcium formate being available this year, put it that way. I think optimistically we may be looking at 4 to 5 years down the track, I think. But we'll see how it goes, and hopefully all goes well, because once a new drug's been sort of proven in a sense as working, then it has to get approvals from the various pharmaceutical regulatory bodies in all the different countries. So there's a lot of paperwork and fiddling around and red tape that needs to happen.
That's fantastic. Thank you, Michael. We'll actually go with another formate question, actually, from Arusha Sani. Thanks, Arushi, for the question. Thank you very much for your interesting talk, Dr. Chan. Which formate compounds are edible or available commonly?
So the compound that's being formulated for the trial is calcium formate, but my understanding is you could also make sodium formate and various other versions of it. I would say please don't go trying to find it yourself, because we don't know if it's safe. We really have no idea at these sort of doses whether the compound might cause problems or not. So for example, the calcium formate, there's a fair bit of calcium in it. So we have to be careful about how much we're giving. You can cause serious health problems giving too much calcium. And we just don't know what's going to happen. And it's the point of running a well thought out and monitored clinical trial in the first place is all about safety. So I'd really discourage people from trying to find formate on their own.
Wonderful, Michael. Thank you. We're actually going to cut to a question for you, Kate, please. A question, we've got a number of people with HCU and family members and carers on the webcast tonight. And so there's a question asking about how you balance meals at home, whether or not you would suggest having people having separate meals for people with HCU and those that don't, or how would you recommend doing that?
Yeah, that's a really good question. So like I sort of pointed out in the slides, a lot of meals can be modified to make them vegetarian. So I think it's great if you don't have to cook lots of separate different meals. So it might be a case of, serving a pasta dish. And for the person with HCU, you could use the low protein pasta and all of the veggies that the family are having. And then the protein is kind of like the meat that the rest of the family would be having. So you should kind of see it that way. Don't know if that's helpful or not.
Great. Thank you so much. And another diet-related question, which is from Deanne Norris for you, Kate. My son is a patient at Queensland Children's Hospital. He'll soon be old enough to start trying solid foods. Is it possible to access the diet management resources from Westmead online or some other way, or are they commonly available throughout Australia?
Our local resources, we're always really happy to share it with any other hospitals. So we often do share resources. So if the Queensland team don't have resources that, or you'd like to request them via the Queensland team, I'd be more than happy to share it with them.
Great. And another sort of diet-related question, I think, Kate, is from Sarah Chadwick asking if there's a website that you'd recommend around sources of low-protein foods.
Yeah, so there's some really good recipe websites. So Cook for Love is really good. There's a really good Irish metabolic website. And then most of the companies also have recipe pages on their websites. So I'm happy to share those links with you. We've got a standard link that we send out to lots of our patients. So just let me know. I can do that after the session.
Yeah, we could probably send that link out via HCU network, Kate.
Yeah, yep, absolutely.
Great. Thank you. We've got plenty of time for questions, so please do keep the questions coming through because it's just so great to have people like this available to us, to experts available to answer our questions. So a question for you, Michael, from Deanne Norris. What do you think is a realistic timeline for these new therapies to be approved and available in Australia? For example, the formate therapy or enzyme therapy?
Yeah, I think the pegtibatinase, which is the enzyme therapy, that's certainly the closest. The enrollment for that study is ticking along pretty well globally. So if you are a person with homocystinuria who wants to wait for the trial to be finished and then for the treatment to become available through the kind of normal official channels, then for pegtibatinase, I think if it goes as well as is hoped, we may be looking at 3-ish years, because we've probably got another year or so at least of the clinical trial to get through. Formate's a long way away. I think realistically probably 5 years away. And I don't know where gene therapy is at the moment. I think if you are keen on getting access to the more advanced therapies, really your only option is to try and get involved in clinical trials. They're a great way of getting involved in advanced therapeutics. They're not for everyone, because of course, there's some risk involved because you're taking part in a medical experiment in a sense, and the time commitment to be part of a clinical trial can be significant as well. So they're certainly not for everyone. I know my clinic and my colleagues in Victoria or in Brisbane are really keen to offer these sort of trials to people, but we certainly don't expect that people enroll in them.
Great, Michael. Thank you. I think that's actually a beautiful segue into a question from Tara Morrison, and that is for you, Michael. Which clinics will be offering the clinical trials, and is it possible for interstate patients to participate? Do you know?
Yeah, certainly to answer the second part, interstate patients, absolutely. Most of these clinical trials are sponsored, and the companies that are running them are more than happy to pay for people's travel and accommodation as part of the study. That's generally not an issue at all. Where they are available, Formate is pretty sure us at Westmead in the adults, Melbourne in the adults, and Adelaide at the adults. It's not a study that's being open to children at the moment, for safety reasons. Pegtibatinase is, we hope, going to be available in Adelaide and Sydney, but as I said, the company have suspended enrolment in that trial at the moment, and we don't really know when they're going to reopen enrolment, but it sounds like it's going to be early next year.
Great, thank you. Um, I'm just going to, while we give the audience some time to submit some more questions, I'm just going to cut to a little bit of a promotion for the HCU e-network. We'd really like everyone who's joined today and people who are involved in HCU, whether you're a patient with HCU, family members, carers, and healthcare professionals, we'd love your participation in the HCU e-network. It's a forum for people to be able to support each other in a sort of community way, ask questions, share answers to questions, share your experience. And I think we really want to make sure that patients and family members are being supported in the best way possible. So please do jump on the HCU e-network, and if you've got questions, then you can ask them, and maybe you can help out people with your sharing your own experience. For people to be able to support. So I'd really like to then cut to a very general question for both of you, and that is, and I think how would you best support someone with homocystinuria? Can we start with you, Michael?
Yeah, sure. Before I answer that, I might just mention that the pegtibatinase study is a global study, and I know we have international guests on tonight's webinar, so there are other countries where the study is being performed. I just don't have that at my fingertips, but I don't think too hard to find that information if you Google it. How do we best support people with homocystinuria? I would hope we can support them in a holistic way. We, from a medical perspective, of course, we do tend to focus on the numbers, the blood test results, but I hope that we also would look at people and how they're going in life, what supports they might need beyond just their blood tests and their medicines and their dietary support, because I know that people with particularly pyridoxine non-responsive homocystinuria could do with more support, whether that's through the NDIS or whether it's school supports or those sorts of things. So, I'd like to think we try and do that sort of thing in clinic. Kate, I don't know if you have anything to add.
I don't know that I have too much more to add than that, but I really agree with the holistic approach is really, really essential because, as Michael said, we tend to just focus on those numbers in clinic, but we understand that there's a lot of challenges involved in managing HCU. So trying to provide support in whichever way we can.
Wonderful, thank you. Another question for you, Michael, I think, is if this is from Ben Fitler, if someone was to join a clinical trial, are they generally able to continue treatment once that trial has completed, or is treatment then cut off?
It's a bit variable, Ben. Many studies, they will continue the drug, particularly for those early phase studies. So if you get in early and you're one of a small number of patients in what we call the phase 2 studies, generally, if the phase 2 goes well, the companies will then move on to the phase 3 studies, which are bigger. But for those patients who are on the phase 2 part of it, they nearly always continue the drug through that time frame when the phase 3 studies are going on. Once the phase 3 studies are finished, then it becomes a bit hit and miss, depending on the study, depending on the company, depending on the results. I would say it's probably about 60-40 that people get to continue the drug.
Great, thank you so much. We have just opened up a feedback survey on the page too. We really do value your feedback. We'd love to hear from you. If you've got any suggestions for future educational activities, we'd love you to participate in the HCU e-network. And people who have registered for the event, we will add your registration to the HCU e-network, and you'll get a welcome email if you're not already a member, so that you can join in the conversation there. Really say a big thank you to both Michael and Kate. We've really been blessed to have your time and sharing your expertise with the HCU community. Ben says thank you very much, has been very much appreciated. Sarah, that would be great, thank you. So positive feedback from the audience. I really appreciate your time and for sharing your expertise with us today. And we do hope everyone can join in the conversation. There is a part of the HCU e-network which is all about diet and nutrition, and maybe you can submit your questions and have ongoing conversation there. And there's plenty of other topics in there as well. So at that, I think we'll wrap it up unless we've got any more questions from the audience. Thank you very much, Michael. Thank you, Kate, and good night.
Pleasure. Thank you very much. Have a good evening.